Yeah, that was
I
pretty.
guess they went back to you
That was
only
pretty
get
whack.
1 hour.
They said the hour. That's it.
They went right back.
Yeah, that's pretty whack. I just tagged it as part one. So that's
Okay.
um that was weird though.
Yeah, it was exactly to the T.
Yeah, to the T. I was like, yeah. I guess they on that now.
Man, we was getting away good. I told you we ain't had
We
that
were
versus money. See, I should have did the surrogacy. I would be retired by now.
right.
Because it was a lucrative offer, but I just was in a different mindset back then.
Yeah, it gotta be lucrative to do that. All right, get back.
All right. So I guess they would have to start over with the questions in the actual chat, but I still got some submitted. Okay, so the next one is, what are your thoughts on yearly mammograms for a 73-year-old woman who's had negative screening since the age 40? My primary care physician has said every 2 years now, but is the radiation risk greater at this age?
Radiation risk isn't greater, but it's just not recommended. It's not recommended after 70. So breast cancer screening stops at 7 years old. So you don't need to have mammograms at that point. That's when it ends.
Well, they're saying that their primary care told them they still got to do it every 2 years.
All I do is read the guidelines. Evidence-based medicine is all I do. So primaries can tell you whatever they want to tell you. It's clearly stated in the guidelines, unless there's some new guidelines that I haven't read about, which could possibly be it. But everything that I know, they stop at 70. So then all my patients, I stop them at 70. Just like pap smears stop at 65, because the risk, everything is risk versus benefit, right? So the benefit for a woman at that age getting mammograms, you're not going to catch new breast cancer at that point. Usually they presented themselves at that point, so it's just not efficient unless a woman has had a history of breast cancer or a strong family history of breast cancer at that point, which by then she would have had it or had some type of issue. But it ends at 70. That's the guidelines, and 65 for pap smears.
Okay.
So tell your primary to just be like, where does it say that in the guidelines? You can ask that. It's fair to be like, what do the guidelines say?
Right.
It's very easy. Like anything I talk about, I tell patients, like, challenge me. Just be like, where does this say that? Like, where in the textbooks or in the standard of care? That's the word you want to use. You want to use standard of care. You ask, where in the standard of care are the guidelines, whatever you're asking about? That's a very fair question. And if they can't show you that that's the standard of care, then don't do it. That goes for me too. If I'm outdated and I'm giving you something that's not in the standard of care, call me out on it.
All right. Is it possible to have multiple orgasms after suffering a stroke?
Yes. There's no reason why not. Those nerves aren't gone. So it's a mental thing. I mean, orgasms have a lot to do with multitudes of different things, and a lot of it is mentality, as well as your pelvic anatomy. So yeah, you could definitely have she said, what freak ass?
This is a judge-free zone. We don't call people names.
Man, y'all ain't shit, man.
I told you the comments, it'd be hard to keep a straight face.
No. But yes, you can't have it, man. Whoever asked that, don't worry about it, man. Listen, it's judge-free zone. Go ahead.
Judge-free zone. That's why I asked. Whatever y'all send me, I asked. Now, I do leave off some of the, can you hook me up with DocP stuff off the list? But other than that, I ask everything.
Hell nah. It's hilarious.
All right. Next question. What do you think about refusing surgery for fibroids if they aren't causing you any issue, but you do know that they're there?
Absolutely refuse it. Absolutely. And if somebody's pushing you to have fibroid surgery and you don't have it, if somebody push you to have surgery anyway, you need to stop. You need to tell them like, nah, unless they can explain like what it is. Like, for instance, I had to push Cola a little bit to have surgery because she needed the shit. You know what I mean? It's like she was like fighting herself when she really, really, really needed it. That's a different situation. But if you're not having no problem, not having no issue, and somebody's like, yeah, just go ahead and get a hysterectomy, find another doctor. Like they trying to, pad their numbers, pad their pockets. Like they're not really looking out for you for help. I don't want to operate on anybody that doesn't need it. I'm gonna tell you in a heartbeat, like, because one, it's not good for you. I'm not putting you in a good position. Two, I'm putting myself at risk. Every time I take somebody back to surgery, it's a risk. Um, so I want to take a risk when it's going to benefit or help someone or when it's needed. Other than that, I'm not telling you to do no damn surgery. I don't want to operate on you. I only want to operate on people that need my help. That's it. And that's how everybody should think. Everybody doesn't think like that. So be cautious about it, but that's how people should think.
All right. Question in the chat bubble. Can you explain UFE and your opinion on it?
Good boy. Jesus.
They showed violence on that one.
Okay. All right. So for all of you all that have heard the explanation, forgive it, but some people, I have to talk like there are a million people here that have not heard me talk about it. And so if you value my opinion, I'm going to give you my full opinion every time somebody asks me a question. That's what these are for. So, and whoever is a radiologist or a friend of a radiologist or have any like radiology people or what have you, or doctors that are not good at fibroid, gynecologists that aren't good at fibroid surgery, or shoot everybody to get UFEs or whatever, I don't give a shit. I don't care. Like I give my opinion no matter what.
Yeah, that's what the question said.
I don't. So, all right, let me start off with what a UFE is. So, a uterine fibroid embolization is when you go to a interventional radiologist and they scan your belly, right? They scan, ultrasound scan your fibroids, and then they map out your blood vessels to that fibroid or the fibroids, and then they go through your groin, right, with a catheter and wires, and they send an agent to cut the blood supply off to the various fibroids, right? This causes what's called ischemic necrosis, meaning cutting off the blood supply, no oxygen to tissue. It's similar to if you sit on the toilet and you sit on your hands for an hour and then you try to pull your hands up, they hurt, they're tingling, the back of your legs are tingling because it has not had blood supply. Hypoxia, or the lack of oxygen, is painful, right? The difference is that when you get off of the toilet, get off of your hands, blood flow rushes back to your hands and to your legs, so the pain goes away. Well, when you cut off the blood supply to your fibroids, the blood's not coming back, so ischemic necrosis can be extremely painful. In my experience, I have had horrible outcomes. First of all, I've never recommended or sent anybody. I won't say never. Let me stop. I've had a few instances. The only times that I've ever sent somebody for a UFE or what have you is if they have been like debilitated. So like patients that are not candidate for surgeries, that needed like surgery, or they were bleeding extensively after a procedure or what have you. Like, so there are specific instances, which are rare, like 1 in 100, in which you may need a UFE. So I'm gonna say never. However, I don't send people routinely for UFEs. I am not an advocate for UFEs, and the reason for that is this. I have taken care of too many women with fibroids that have had UFEs, that have had pain, that have had issues, that have not worked. If you give me 10 women that have had a UFE, in my experience, again, I'll preface that with my experience, 8 or 9 of them are going to not have a good outcome. They don't they either have pain, have consistency with their issues, have problems. It's not good, right? In addition to that, when you go in and operate on somebody that has a so these are people like, I had UFE and it's great or whatever. Have you ever went into somebody's belly to do a fibroid surgery and touched a fibroid or had a fibroid in your hand? If you have not, because I have, right? And I have pictures. If you ever want to see them, I will show you what fibroids look like, what ischemic necrosis look like after UFE. It looks like a big ball of chocolate necrotic garbage that's going to just sit there. It's not going anywhere, right? Those women suffer with that for extensive period of times. When you can't have a UFE, you can't have like something like an excessa. You can't do that procedure or whatever because you have ischemic necrosis. So for me, I would, and this is what you ask a doctor, what would you tell your mama to do? What would you tell your sister to do? I ain't telling my mama, my sister, my auntie, or my dog, which I don't have a dog, but if I did have a dog, I would not tell any of them or recommend any of that or recommend UFE to any of those entities. Nobody. I'm not going to tell them to do it because, again, it's my experience. You might have your auntie's cousin, mama, sisters on the third cousin on your sister's side may have had a UFE and did well, but everybody else that had it did not. So with that being said, it is not good for me. It's different. So people are like, well, then what is it, what you do with excessa? Because you hear the word ablation. It's different, right? So a UFE or uterine fibroid embolization is different from excessa, which is a laparoscopic radiofrequency ablation of a fibroid. Huge difference. UFEs are dealing with the blood supply, cutting off of the blood supply to the fibroids. Excessa or laparoscopic radiofrequency ablation is actually going to the fibroid and actually burning the fibroid. It's not messing with the blood supply. It's not causing ischemic necrosis, right? It's causing it's causing the treatment or the heating of the fibroid in its direct tissue and not messing with the blood supply, which is why it's different, which is why it's effective, which is why women don't have problems or pain or issues with it. You can argue about like the effectiveness of it, but they don't have the pain and the other issues. So that's why I'm a proponent. That's why I teach people the surgery. That's why I think it's a very viable option to treat fibroids as opposed to UFE. I will never recommend anybody do a UFE, but with that being said, I will if anybody's ever done a consult with me, I'm never not giving it as an option either, because no doctor should take your option away from you. So I give you the option of UFE, and if that's what you want, then absolutely your doctor should provide it for you. I just personally don't recommend it, or do I, really think it's a great surgery. But that's my take on it. Hope I got I really hope people actually listen to that, because I'm gonna get that question again. I hate talking about it.
All right. Can a woman have an ectopic pregnancy after having a partial hysterectomy but have ovaries?
I have to read it. I'm sorry. All right.
So
I have to read it again.
Okay.
No.
Can a woman have an ectopic pregnancy so she still has her?
She has her. So one.
It's the partial hysterectomy.
I would really hope that people that are doing hysterectomies are taking the fallopian tubes now, too, because the reason why is because many ovarian cancers we have found actually originate in the fallopian tube. So now we should be taking fallopian tubes anyway. But if you have had a hysterectomy, I'm sure there's a case report somewhere, but it is damn near impossible for you to have had an ectopic pregnancy after that, because there's no pathway for the sperm to actually get to the egg, unless the only way I could see it is if you had a super cervical hysterectomy. There's still some pathway for the sperm to get up through the cervix into the pelvis, and join an egg, fertilize, and then get pregnant in it. But that would be extremely rare for that to happen. So when I say impossible, no, but like you should play the lottery if that happens.
All right. Um, can untreated fibroids damage parts of the urinary tract or any surrounding bodily structure?
Can they damage?
Yeah.
They can cause problems.
Okay, I'm gonna be right back.
Go ahead, that's fine. So yeah, so fibroids can get large to the point where they can cause problems. So fibroids can actually push on the ureter. They can push on the bladder and cause urinary frequency. I've had a patient that I've operated on, well, multiple patients actually, but one in particular that I'm thinking about where she had hydronephrosis from her fibroids to where the fibroid was so large it was pushing on her ureter and was causing her to have kidney failure and kidney issues. So yes, it can. It should be reversible once you remove the fibroid or once you remove, that mass off of, the urinary structure. So meaning, yes, can it cause damage, but it's not permanent. It's temporary issues.
Okay. Another question in the chat. What does a soft uterus mean? My doctor mentioned that after my surgery, I had an oophorectomy.
Oh, oophorectomy?
Okay, sorry. Oophorectomy.
No, but she said, what is it? Salt? Is it salt? What is it? What's the question?
What does a soft uterus mean?
A soft uterus? I have not heard that term of a soft uterus. So mind you, I'm not talking about anybody, but sometimes people will use terms that are not correct. And that's not you doing it. That's just you hearing somebody telling you that and they're telling you improper things. And then like it's being perpetuated. Kind of similar to the big thing about tilted uteruses, right? I hear this all the time. Is it a thing? Kind of, but it's not what you think it is. It's like every uterus is tilted. So it really does not mean anything, but people have a misconception that it's really something big. But a soft uterus should be somewhat soft, shouldn't be hard. If it's hard, that means it's fibroids or something else that's causing it to be that way. Um, but yeah, big soft uteruses like adenomyosis can cause a huge soft boggy. Maybe boggy is the term that they're talking about. So a boggy uterus, which adenomyosis can cause.
All right. If you rejoined us, you can still request to join the live. We're gonna go about 10 more minutes.
Yeah, cut it off.
And then, so if you want to join the live, you can request to join it and get a free consultation on site. Otherwise, I'm gonna keep going with the ones in the chat. And what is your opinion of VBAC after open myomectomy or oophorectomy? Is it too much risk?
Great question. So the question is, what's my thought process of VBAC, which is a vaginal birth after cesarean section, after an open myomectomy or major uterine surgery? And my opinion about it is not recommended. Right. So if you follow the guidelines, and the reason why it's not recommended is because there is a 3 to 4% risk of uterine rupture. Right. So that is a surgical emergency. That is a risk of death to the mom and to the baby. Is that risk really worth it? No. Right. Everything is risk versus benefit. So with that being said, all myomectomies are not the same, meaning is like, for instance, we talked about the myomectomies where you're removing a pedunculated fibroid off of the uterus, which doesn't really change the architecture of the uterus. That's different than a fibroid that's actually pushing all the way into the cavity of the uterus, right? But with that being said, if a patient unless I perform the surgery and I know exactly what type of fibroid she had, I'm not doing anything. If you have come in to me from Joe Schmo doctor that has done your myomectomy, we doing a C-section. Not doing that because of the risk. It's not worth the risk of me trying to let you deliver vaginally. Something bad happens and you go to Joe Schmo attorney at law to try to come after my kids' college funds because you wanted to have a vaginal delivery. It's just not worth it. The risk is too high for rupture. So if you came in, like for instance, if you had a myomectomy and you came in 10 centimeters dilated and the baby's head was right there, whatever, sure, go ahead, push it on out. But that's less than 1% of the time. Usually you have that myomectomy, you're going to go into labor, and we got a decision to make. And that decision is going to be to perform a C-section because of the risk that one of those incisions are going to come open as you push. Realize that pressure always follows the path of least resistance, right? So, for instance, let me give you this example. If you play basketball, right? Love Derrick Rose, but when he blew out his knee, when he went and played basketball, when he came back, what was the first thing that was going on? His knee, right? Because he's putting a lot of torque, a lot of strain, a lot of movement on his body, and that pressure is going to find the weakest point. It's the same way with uterine surgery, right? So when you take a fibroid out of the uterus and then you repair it, now you have a full-term pregnancy and you pushing this baby, trying to push this baby through this little bitty hole. Push, 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 push. It's either A, going to go through that hole and deliver, or B, the pressure is going to become so great that the weakest point on that uterus is going to come open. What's the weakest point? The point where it's the defect that you took the fibroid out of it. So you are rolling the dice that woman pushing, the thing that's going to break first is the baby actually going through the canal, as opposed to the pressure being so great that it's going to cause that weak point of the uterus to rupture. It's just not a risk you want to take. You just want to do C-section. Don't play that tug of war risk with hoping that incision stands up as this woman pushes through trying to get this baby out.
All right. Next question, and I'll take the last question out of the chat for tonight since we had like 5 more minutes. All what right. is a punctate? Wait, P-U-N-C tate, T-A-T-E. Punctate?
Yeah.
Okay. Right ovarian calcification.
Let me see that. That's not
look in the box. It's the P-U, it's the...
Where is it? It's in there.
It's near the bottom.
Insurance cover and sister website. I don't see that. That's on your side, I think. Yeah, I don't see that.
Okay. Well, I don't know if I'm saying it right, but it's spelled P-U-N-C-T-A-T-E, so punctate.
Yeah, punctate. That's like a rupture of blood vessels. That's typically what you see on a colposcopy when you're doing like a colposcopy, like a punctate hemorrhage. Mm-hmm. They're asking about.
They said punctate right ovarian calcification.
They're mixing in terms.
Okay.
They're mixing in terms there, so it's they have to specify that because I think they read something on an ultrasound or read something somewhere and didn't describe exactly what it said on there because those two terms
don't go together.
No, they don't go together.
Okay. All right. Well, I'll take a different one. We did that one. What insurance covers the HFU for fibroids?
The HFU.
Yeah, I don't. They didn't. They just says FHU. I mean, no, HFU.
I boy, I be having to decipher this stuff.
I
So they're
know, right?
asking for, are they talking about like the embolization? High frequency ultrasound, HFU. So where y'all getting this from? So,
I
so
know.
yeah, so ultrasound, like you can change the frequency on ultrasound, like just depending on the machine. Um, so that's really just depending on the type of ultrasound equipment that your provider or whoever has. So we don't have a code for high frequency ultrasound. It's transvaginal ultrasound, it's abdominal ultrasound. There's not a special code for high frequency ultrasound. So you can change the frequency up on the ultrasound. It's just going to show you a slightly more specific image. So that's just like a misnomer. If you need a ultrasound, you get a transvaginal ultrasound, but insurances are going to pay for transvaginal ultrasound. Now, if your provider cranks up the frequency because they have like the special new GE 2022 model QFCQ whatever, right? And they can now pinpoint and change the frequency on it. Then yeah, they can do that on their own, but they're not gonna get paid no extra bread because they got this specialty machine. They're gonna still get paid the transvaginal ultrasound charge.
All right. If a woman has multiple sclerosis, does that affect Kegel muscles as well?
It affects the nerves, right? So MS affects is nerve issues. So it doesn't necessarily affect the muscles. It affects the nerves that innervate the muscles. So yes, MS can impact pelvic nerves, just like it can impact any nerves in the body. Um, so yeah, people with MS can have issues with urinary retention and urinary frequency and those types of things just from the impact that the disease has had on the nerves of the pelvis. So yeah, it can have an impact, but not the actual muscles of the pelvic floor. Um, if that answers the question.
I think it does. Okay, so last one for the night because I don't want to keep you forever. Um,
They
what
cut
is
us off.
what? Say it again.
Therefore, they cut us off.
Yeah, because I was gonna say, shoot, I told you gotta cash in on your retirement so we could
I'm
buy the
telling you, man.
time like
Look,
hearses and go all night long.
the
All right,
magical
last.
elixir, man.
Well, we'll end on this note this month because we'll do next month, of course. They said, can we get a clinic update, a practice update?
Yes. All right. All right. I know y'all tired of hearing this shit, and I'm tired of saying it. And I just had this long conversation. I've been in meetings and stuff like all week about this, and so I am I am still independent. And the reason why I'm staying independent is because I don't want anybody telling me what I can and what I can't do as far as patients and things are concerned. I want to be able to do my lives. I want to be able to talk to people that are in different states, have them come and fly in for surgery. I don't want to be under the thumb of any hospital or any entity. Um, that takes time. That takes a lot, especially when you're trying to navigate in Chicago doing that. So it's taking a little bit longer. In addition to that, I'm not a sellout. Not I won't say that. I don't. I value staying in my community. I value being able to take care of people that look like me and people that need me, right? Northwestern, all of them hospitals up north or whatever that would pay me, way better and would, I would not have all these all the hassle. Um, it doesn't matter to me. I can't do that. I stay in this community with that. Um, Knowing that I can continue to take care of the people that I want to take care of. With that being said, I still got to deal with my people. So it just is what it is. So like, yeah, you know what I'm talking about. You know what I'm talking about. It's just different from an efficiency standpoint and as far as like, getting things squared away. With that being said, where I'm at right now, I have signed the contract. The contract is completely signed. My name is on the dotted line. I have insurance. I have all of that stuff. Everything is really set up. I am in the process of credentialing. I'm going to undergo for credentialing of the hospital. So the hospital is Mount Sinai, which is on the west side. The question came up, am I still at Ingalls? Yes, I'm still at Ingalls. This is Ingalls right here. I'm here every Thursday. So yes, I'm still at Ingalls, and I will be operating at Ingalls still. Like, I haven't given up my privileges because I still want to do robots here. I still want to serve the community of people here, but I need a clinic. That clinic will be through Mount Sinai. I cannot give out the exact address, but if you're really, really smart, just know that it is through the residency program of Mount Sinai, where I'll be teaching residents and doing that all of that stuff. It is literally 3 blocks. It's on Kedzie. It's 3 blocks from the hospital on Mount Sinai on the west side of Chicago. So that will be opening soon. As soon as they give me the okay to be able to say, all right, this is exactly when we are letting you in the doors, this is exactly when patients can come in or what have you, then I will release it all over the place. Everything I do, it will be in the comment section. It will be on my page. It will be everything as far as like where you can call in, where it's at, all of that information. And I know I keep saying soon, but I promise you, this month I will be releasing that information for everybody. And with that being said, all of the patients that I promised surgery to, you will be getting calls actually this week and starting next week, because I want you all to start going into to get your information into the system, what have you. So when I can start operating, that we can do that right away. Like, it's not going to be any lag time. So I plan on starting to operate hopefully by end of November, December, probably December, honestly, to be honest with you. December. So when I start, I can get those things going. So I have partners that are actually already there. So if you don't mind, you'll see the partners that I have there just for your visit. Not that they're going to be doing your surgery, but just for the visit, just to get in the system. And so that when I do get there, everything is seamless and we can start operating right away. That will be starting in a month. So be on the lookout for that. And like I said, everybody that is on my books for surgery, I've not forgotten about you. I'm literally making calls tomorrow to everybody to let you know that you will be getting phone calls next week to start setting up insurances and those things to get ready for surgery. No, I did not say that I'm not with Ingalls. I'm still with Ingalls. I'm here. I never said I was leaving Ingalls. I said I was leaving Gynecology Institute. That's why I said I was leaving. I'm not doing that no more. But Ingalls kind of near and dear to my heart. Like, I'm still gonna be here. I love this community. I still gonna operate here. I still take calls here. I still do my little bit of OB here. So for the foreseeable future, I don't see myself just leaving Ingalls. I'm still gonna be here doing stuff as long as they have me here. But it'll be between Ingalls and Mount Sinai. So that's all my information. And I promise you the number and all of that stuff will be available within the next few weeks. I just have to, as much as I want to tell y'all, like, start calling these numbers, y'all gonna call and they're gonna be like, we're not ready to take you and do all that. When I give the number and I give the information, I want you to be able to call and people talk to you, get your appointments quickly, having very, very, very open and transparent communication, which is the reason why I left my practice, because I don't want to have anybody have to deal with communication that's not up to par. Like, I want, when you call, to be able to get the treatment. I don't care if you got Joe Schmo insurance, the worst public aid insurance, or if you got the best designer, Blue Cross Blue Shield, gold platinum package. Everybody should be treated the same. And that's how I want everybody to be treated. And even if you calling in from out of state or whatever, people should be handling you that way. They should be making sure that, if you don't have the right insurance, how you can get the right insurance or what you need to do to get your surgery done. It should be very, very helpful to you. And that is what I'm making sure is in place before I start having people call. But I promise you, I will never be anywhere for any extensive period of time that doesn't do that, which is why I've been not operating and kind of in limbo, because if it ain't right, I don't want to do it. Hope that answered everybody's question.
Yeah, definitely did. All right. Well, Doc, I definitely appreciate you as always. We all appreciate you.
Well, thank you guys. I said, please do you do dermoid ovarian cyst surgery? Yes, I do dermoid. I do pretty much anything that laparoscopic. If it's gynecologic, I do it. So yes, I do. And like I said, I have a eager staff. Like, it's the great thing about Mount Sinai is that like they have a residency program, and I'm going to be like teaching the residents. Again, they're not like, people are scared of like residents and like, oh, they're gonna be doing my stuff. No, I am still doing the surgeries. I'm still going to be in charge of everything. But the beautiful thing about residents and working with residents is that you always have, they really really want to care for you and to make me happy. So with that being said, you can pretty much talk to a doctor all the time, right? And have somebody that's like really making sure all of the T's are crossed, the I's are dotted, and making sure you have everything you need. That's why I like working with residents, and that's what is going to be different moving forward with everybody that's coming in for surgery. Now I'll be working with residents and a staff that's equipped to take care of everybody.
And you'll be teaching people
And I'll
to
be
care
teaching.
about patients. Like, you're a patient advocate, they'll be patient advocates because
Yep.
they'll be mimicking you. So
Yep.
that's good. We need more people that think, give the patient a voice in the medical community, because that's what a lot of us lack, having that voice.
Do your research, people. I mean, I try to tell y'all as much as I can tell y'all without telling y'all without being a snitch. Because I can't be, it's just like, like cops coming to the hood and like, who did it? I can't necessarily blow the whistle on my colleagues or whatever, but I can tell you, like, there's a lot of fuckery going on, right? So please do your research on who's operating on you and who's taking care of you. That's all I can really tell you. I can't whistleblow, but I just have to tell you, do your research. And there's some people out there that I wouldn't send nobody in my family to, or anybody that I know to, right? And that information, you need to know that, right? So do your research. And one big thing, like, how do I know? How do I know? Like, all I could do is Google search. I look at it like this, and I'm gonna say this and I'm gonna be done. Social media is a very powerful thing. Like, we have multiple different outlets and things that allow us to see what people really are like outside of their work environment and what they do. And for me, if someone is like, Cola, you do hair, right? Right? You're very vocal about that. And if I look on your page and I look on the things that you do, I could tell that you're passionate about what you do. So if I'm a women's healthcare expert, right, and I care about Black women, and I care about, the care of everybody, then my social media and the things that I do outside of the hospital should reflect that, right? So if you don't be afraid to go research your physician and your surgeon and see what their social media look like,
Yep.
right? If they really about that life, like, they should have that reflective, in their social media stuff. That's what my advice to you is, and that's what I'm gonna tell you. That's without me telling you. Like, really use that to your advantage. And when you're picking people that's going to take care of you, and it's not just OB, it's pediatric, it's everybody. Like, they need to be reflective of what they're about. So do your research on them, and that's a lot of stuff available for you and a lot of information on people. Like, use it.
I agree. I literally watched DocP for a year. Not that everybody should wait a year with what I was dealing with, but but I really literally watched. Was he consistent for about a year before I could even trust to go to an office visit? So I was like, okay, he's actually consistent, and it actually is the same message every time. So it was kind of like, I really, 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 really research, like, hands down.
I implore it, and like I said, anybody that doesn't listen to you, and that's another thing. Like anytime you go to somebody, number one, they should listen to what you're talking about, right? They shouldn't just tell you like, oh, talk over you. They should break things down for you. Like you're confused, they shouldn't just be trying to rush you out. They should be breaking this stuff down to you, and then they should be treating you like this is a partnership. Like if we talking about surgery, we talking about treatment options, is not what I feel. Just like I said, I don't like UFEs. I'm not going to not give it to you as an option. I'm going to give it to you as an option, even though I can give you my opinion, but I'm not going to rob you of your ability to make an informed decision. So if you get the feel that somebody's not giving you options, that they're kind of dictating to you and you're not comfortable about the relationship as far as like, are they really listening to me? Please keep it moving. Please keep it moving. I don't care if
get your purse.
Yeah, get your purse and be out. Like I don't care who's been to them and who say they great or what have you, such and such. It just makes me cringe right now. I got physicians that I know here that like I'm like, why are you going to this person? Or like, why are you still operating on Black women? Or like, why are they still listening to you? And it's just like, it's word of mouth. It's like such and such went to them, such and such went to them, and they're not doing their research. But I can't go into the operating room and start smacking scalpels out of people's hand. You know what I mean? I can't go in there and start kicking people in the back, telling them like, man, get off that one. Like, I can't do it. But all I can do is tell y'all, what I see and what's happening, and just, try to put you on game, and hopefully you use it to your advantage.
Yeah, because they can't fool you forever.
They cannot. But man, you'd be surprised. It's bad stuff happening out here. It is. It's really unfortunate. But I don't know how to. All I can do is try to teach and try to educate. But if people are not going to listen, like I can't fix it all.
Well, I always tell you the city needs you.
I'm trying. I'm trying.
All right, DocP.
All right.
Thank you so much. And until next month, we'll be back.
Next month. And then y'all send all your questions in, Nicola, and we'll do it. And I'll post this one too. I'll just put this as part 2.
Yeah, I'll break it up, and I'll also record it for if you need to share with someone who doesn't have social media. I do reshare to YouTube later, so anybody can have access to the information, because definitely patient advocacy is my passion as well. So
awesome.
All right then. Well, I will see you next month.
All right, y'all.
Talk to you.
Be safe.
Thanks, everybody.
All right.
Bye-bye.